Melanoma is a deadly form of skin cancer arising from melanocytes. While it accounts for a small percentage of skin cancer cases, it spreads rapidly and invades other organs. Early detection is crucial. When caught early, melanoma is highly treatable. Delayed diagnosis reduces survival chances, emphasizing the need for vigilance. This lecture will equip dermatologists with essential insights into melanoma. Recognizing melanoma's visual cues is vital for early detection. The ABCDE criteria help evaluate suspicious lesions: asymmetry, border irregularity, color variations, diameter over 6 millimeters, and evolution. Melanoma can mimic benign moles, making a high index of suspicion crucial. Accurate diagnosis involves clinical evaluation, dermoscopy, and biopsy. This masterclass will guide you through melanoma diagnosis and treatment. Melanoma is a global health concern, with high rates in Australia, New Zealand, and Northern Europe. UV radiation is a significant risk factor, especially in fair-skinned populations. The U.S. also faces a considerable melanoma burden. Proactive skin cancer screening and prevention are essential. Understanding global melanoma epidemiology underscores the need for a unified effort. Some individuals are more susceptible to melanoma due to intrinsic risk factors. Fair skin types, Fitzpatrick-Weston 2, are at higher risk due to less melanin. Genetic mutations in genes like CDKN2A, BRAF, and NRAS increase melanoma risk. These mutations disrupt cell growth and repair, leading to cancer. Heightened vigilance and personalized prevention strategies are necessary. Extrinsic factors like UV radiation from the sun and tanning beds significantly influence melanoma risk. Intense sunburns during childhood and adolescence increase lifetime risk. Emphasize sun protection measures, shade, protective clothing, and sunscreen. Immunosuppression also raises melanoma risk, making regular skin exams critical. Understanding modifiable risk factors is key for effective patient education. Melanoma development is a multi-step process involving DNA damage in melanocytes. UV radiation causes DNA mutations, leading to uncontrolled cell proliferation. Repeated UV exposure overwhelms cellular repair mechanisms. Key hallmarks include uncontrolled growth, evasion of apoptosis, and angiogenesis. Mutations in genes disrupt signaling pathways, leading to tumor formation. Understanding genetic mutations in melanoma aids diagnosis and treatment. BRAF mutations, especially V600E, drive uncontrolled cell growth. NRAS mutations also lead to uncontrolled proliferation. CAT mutations are prevalent in specific melanoma subtypes. Genetic heterogeneity underscores the need for personalized treatment. Genetic mutations in melanoma disrupt critical signaling pathways. The MAP-ERK pathway is frequently hyperactivated due to BRAF and NRAS mutations. The PI3K/AKT/mTOR pathway contributes to tumor progression and resistance. Targeted therapies like BRAF and MEK inhibitors improve patient outcomes. Challenges include therapy resistance and the need for treatments for other mutations. Melanoma subtypes like superficial spreading melanoma, SSM, and nodular melanoma, NM, have distinct characteristics. SSM spreads horizontally within the epidermis, allowing early detection. NM is aggressive with early vertical growth, leading to deeper invasion. SSM is more common and has a better prognosis. NM is often diagnosed at a more advanced stage with a poorer prognosis. Lentigo maligna melanoma, LMM, and acrolentiginous melanoma, AM, have unique features. LMM arises on sun-damaged skin and has a prolonged radial growth phase. ALM affects areas not typically exposed to the sun like palms and soles. ALM is more common in darker-skinned individuals and can be delayed in diagnosis. Thorough skin examinations are crucial for detecting these subtypes. Rare melanoma variants like mucosal, desmoplastic, and amelanotic melanoma pose diagnostic challenges. Mucosal melanoma arises in mucous membranes and is often diagnosed late. Desmoplastic melanoma appears as a scar or nodule, leading to misdiagnosis. Amelanotic melanoma lacks pigmentation, making it hard to detect. A comprehensive approach to diagnosis is essential for these variants. The ABCDE criteria help in early melanoma detection. Asymmetry, border irregularity, color variation, diameter over 6 millimeters, and evolution are key indicators. Melanomas often exhibit asymmetry and irregular borders. They display multiple colors and are typically larger than benign moles. Any evolving lesion should prompt further investigation. Section 2. Beyond the ABCDEs, recognizing atypical presentations. Melanoma can be a master of disguise, often presenting with atypical features that defy easy categorization. Dermatologists must maintain a high index of suspicion, particularly when encountering lesions that deviate from the norm. The ugly duckling sign is a helpful concept in identifying suspicious moles. This sign refers to a mole that stands out from the patient's other moles. It's like spotting an odd bird out in a flock. It warrants closer inspection. Amelanotic melanomas pose a unique diagnostic challenge. These lesions can appear pink, red, flesh-colored, or even translucent. A thorough history is crucial. Dermoscopy is particularly helpful in evaluating amelanotic lesions. advanced melanoma can present with additional features that signify deeper tissue invasion. Ulceration often indicates an aggressive tumor. Bleeding can also be a warning sign. Satellite lesions and in-transit metastases signify tumor spread and carry a poorer prognosis. Recognizing these atypical presentations is crucial for prompt diagnosis and treatment. Diagnosing melanoma begins with a comprehensive clinical evaluation, the cornerstone of early detection. The dermatologist's keen eye serves as the first line of defense in identifying suspicious lesions. This evaluation considers the patient's medical history, risk factors, and lesion characteristics. The physical examination assesses the patient's skin comprehensively, from head to toe. Dermoscopy magnifies the skin's surface, aiding in melanoma diagnosis. While clinical evaluation and dermoscopy provide valuable clues, biopsy remains the gold standard for diagnosing melanoma. This minimally invasive procedure involves removing a small sample of the suspicious lesion for microscopic examination. Excisional biopsy, the preferred method, removes the entire lesion with a margin of healthy skin. Incisional biopsy removes only a portion of the lesion, useful for larger lesions. Shave biopsy is generally avoided for suspected melanoma due to insufficient tissue sampling. Punch biopsy removes a cylindrical core of tissue, suitable for smaller lesions. The pathologist's report confirms the presence or absence of melanoma and guides treatment decisions. Once melanoma is diagnosed, the next critical step is staging, determining the extent of the disease's spread within the body. Accurate staging guides treatment decisions and estimates prognosis. The ABCDEs system considers tumor size, nodal involvement, and metastasis. Tumor size is determined by Breslow thickness from the biopsy. Nodal involvement is assessed through physical exams and sometimes a sentinel lymph node biopsy. Metastasis is evaluated using CT, MRI, or PET scans. The ABCDEs system assigns stages from 0 to 4, guiding treatment and prognosis. Understanding melanoma staging is crucial for providing accurate patient information and treatment options. The foundation of melanoma treatment is surgical intervention. Surgery aims to completely remove the tumor and any surrounding tissue potentially harboring microscopic cancer cells. The extent of surgery depends on factors like melanoma's thickness, location, and depth of invasion. Wide local excision is the standard approach, removing the tumor with a margin of healthy tissue. This margin reduces the risk of local recurrence. Margin guidelines have evolved, reflecting ongoing research. If melanoma spreads to lymph nodes, a lymphadenectomy may be performed. Surgical techniques continue to advance, focusing on minimizing scarring. Mohs surgery is gaining traction for melanomas in sensitive areas, ensuring complete tumor removal while sparing healthy tissue. While surgery effectively removes the visible tumor, microscopic cancer cells may linger in the surrounding tissue or lymph nodes, increasing the risk of recurrence and distant spread. Adjuvant therapy, administered after surgery, aims to eliminate these residual cancer cells, reducing the likelihood of the melanoma returning and improving long-term outcomes. The decision to recommend adjuvant therapy is individualized, based on a careful assessment of the patient's overall risk profile, taking into account the melanoma's thickness, ulceration, mitotic rate, a measure of how quickly the tumor cells are dividing, and the presence or absence of lymph node involvement. High-risk melanomas, those with a greater likelihood of recurrence or metastasis, benefit most from adjuvant therapy. Immunotherapy has emerged as a cornerstone of adjuvant therapy for melanoma, harnessing the body's own immune system to target and destroy cancer cells. Checkpoint inhibitors, a revolutionary class of immunotherapy drugs, have demonstrated remarkable efficacy in improving recurrence-free survival and overall survival in patients with high-risk melanoma. These drugs work by blocking specific proteins, known as checkpoints, that normally keep the immune system in check, preventing it from attacking healthy cells. By inhibiting these checkpoints, checkpoint inhibitors unleash the immune system, allowing it to recognize and eliminate cancer cells more effectively. Nivolumab, also known as Opdivo, and pembrolizumab, or Keytruda, two checkpoint inhibitors targeting the PD-1 protein, have become standard adjuvant therapy options for patients with stage 3 melanoma, significantly reducing the risk of recurrence and improving long-term outcomes. The optimal duration of adjuvant therapy remains an area of ongoing research, with studies exploring shorter treatment courses to minimize side effects while maintaining efficacy. For patients diagnosed with advanced melanoma, systemic therapy is the mainstay of treatment. The goals shift to disease control, prolonging survival, and improving quality of life. Immunotherapy and targeted therapies have revolutionized outcomes for advanced melanoma. Checkpoint inhibitors offer durable responses and improve survival rates. Anti-PD-1 agents like nivolumab and pembrolizumab shrink tumors and extend survival. Ipilimumab, often combined with anti-PD-1 agents, enhances the immune attack on cancer cells. Targeted therapy exploits genetic vulnerabilities in cancer cells. BRAF inhibitors like vemurafenib and dabrafenib improve survival in BRAF-mutated melanoma. These drugs block the mutated BRAF protein, halting melanoma progression. MEK inhibitors like trametinib and cobimetinib further suppress tumor growth. These therapies are combined with BRAF inhibitors to maximize efficacy. Completing melanoma treatment marks a significant milestone in a patient's journey, often met with a mixture of relief and apprehension. While the immediate threat may have subsided, the journey is far from over. Melanoma, known for its potential for recurrence, even years after successful initial treatment, necessitates a lifelong commitment to vigilance and proactive surveillance. This vigilance involves a two-pronged approach: regular follow-up appointments with the dermatologist and active patient participation in self-examination and early detection. Follow-up schedules are tailored to the individual patient's risk profile, taking into account the stage of the melanoma at diagnosis, its thickness, the presence or absence of lymph node involvement, and other prognostic factors. Patients diagnosed with early-stage melanoma, particularly those with thin melanomas and no evidence of lymph node involvement, generally require less frequent follow-up, typically every 6 to 12 months for the first 5 years after treatment. This interval allows the dermatologist to monitor for any signs of recurrence, address any long-term side effects of treatment, and reinforce sun protection measures. As the risk of recurrence increases, so too does the frequency of follow-up. Patients with stage 2 or the 3 melanoma, characterized by thicker tumors, lymph node involvement, or other high-risk features, typically require more frequent visits, every 3 to 6 months for the first 2 years, followed by checkups every 6 to 12 months thereafter. This intensified surveillance aims to detect any recurrence early when treatment is most effective. Section 2. Empowering patients. Knowledge as a shield against recurrence. Patient education is crucial in managing melanoma, empowering individuals to be vigilant self-advocates. Knowledge enables patients to recognize subtle changes and seek prompt medical attention. Teaching skin self-examination is a cornerstone of patient education. Dermatologists should guide patients on how to examine their skin systematically. Use a well-lit room and a full-length mirror, enlisting help for hard-to-see areas. Report any new or changing moles to the dermatologist immediately. Sun protection is a lifelong commitment for melanoma survivors. Minimize sun exposure, seek shade, and wear protective clothing. Apply broad-spectrum sunscreen with SPF 30 or higher regularly. Reapply sunscreen every 2 hours, especially after swimming or sweating. Empowering patients with knowledge reduces recurrence risk and fosters well-being. Section 1. A collective mission, advancing melanoma care. As we conclude this comprehensive exploration of melanoma, its complexities, and the latest advancements in its management, one resounding message emerges. Early detection and precise staging remain the cornerstones of effective melanoma care. Timely diagnosis, often hinging on a dermatologist's astute observation, a patient's self-awareness, or a combination of both, can be the deciding factor between a highly treatable condition and a life-altering diagnosis. The ABCDE criteria, a seemingly simple mnemonic, serve as a powerful tool, empowering both healthcare professionals and patients to identify suspicious lesions that warrant further investigation. However, melanoma's deceptive nature, its ability to mimic benign conditions or present with atypical features, underscores the importance of a high index of suspicion, particularly when encountering lesions that deviate from the norm or raise even the slightest concern. Precise staging, meticulously charting the extent of the disease's spread within the body, provides the roadmap for treatment decisions, guiding clinicians toward the most appropriate and effective interventions for each individual patient. The AJCC-TNM staging system, a cornerstone of melanoma management, provides a standardized framework for communication among healthcare providers, ensuring clarity and consistency in treatment planning and prognostication. As we strive to improve outcomes for all melanoma patients, it's essential to recognize that the journey extends beyond diagnosis and treatment. Follow-up care, a lifelong commitment for melanoma survivors, plays a crucial role in detecting recurrence early when treatment is most effective and addressing any long-term side effects of therapy. Section 2. The power of collaboration, shaping the future of melanoma research. The treatment landscape for melanoma has undergone a dramatic transformation in recent years, driven by groundbreaking research and fueled by a collaborative spirit among scientists, clinicians, and patients determined to conquer this challenging disease. Immunotherapy, once a distant promise, has emerged as a game-changer, harnessing the body's own immune system to target and destroy cancer cells with unprecedented precision. Checkpoint inhibitors, a revolutionary class of immunotherapy drugs, have redefined the standard of care for advanced melanoma, offering durable responses and significantly improving survival rates in patients who once faced limited treatment options. Targeted therapies, another testament to the power of scientific innovation, exploit specific genetic vulnerabilities within cancer cells, selectively disrupting their growth and survival while sparing healthy cells. BRAF inhibitors, initially hailed as a breakthrough in BRAF-V 600E mutated melanoma, have paved the way for the development of other targeted therapies, each targeting a specific Achilles heel in melanoma's armor. These advancements, while remarkable, represent not the finish line but rather a pivotal turning point in our ongoing battle against melanoma. The quest for even more effective treatments, those with fewer side effects and the ability to eradicate even the most aggressive forms of melanoma, continues with unwavering determination. Clinical trials, the cornerstone of evidence-based medicine, provide a platform for evaluating promising new therapies and refining existing treatment strategies. These trials, often involving multidisciplinary teams of experts working across institutions and geographical boundaries, offer a beacon of hope to patients with advanced melanoma, providing access to cutting-edge treatments not yet widely available. Section 3. Looking ahead, a future brightened by innovation and hope. The future of melanoma treatment is bright, driven by recent progress and dedicated professionals. Collaboration across dermatology, oncology, and genetics is accelerating discoveries. Big data and AI are revolutionizing diagnosis and treatment, enabling personalized care. Liquid biopsies promise non-invasive monitoring for melanoma recurrence. The future involves personalized treatment strategies tailored to each patient. Genomic profiling will guide targeted therapies and predict treatment responses. Immunotherapy will expand to earlier stages, improving outcomes. The goal is a future where melanoma is manageable, driven by innovation and hope. Let us carry forward the knowledge and determination to improve outcomes for all. The fight against melanoma demands our commitment, collaboration, and belief in science.